Welcome to the Rex Andrews Show. Glad to have you. If you are a first-time listener, welcome to the program. Glad to have you on board and in the conversation. If you are a return listener, we always want to say thank you. And why do we say thanks? Well, because you have helped us and because of our good guests, which we have a great one here today. But because of the combination of the two of you, we've cracked into the top 10 fastest growing podcasts in the world, which is quite an accomplishment for you because there are more than 1 million podcasts in the iTunes store. And they always debate which number it is, but it's a big number. So you have lots of choices. So thank you for tuning in. All right. Little housekeeping before we get started. If you don't like the platform that you're on, don't worry about it. We're distributed on 23 different platforms around the globe. We currently have listeners in 32 countries, 6 continents. And if we could figure out a way to get smartphones in the hands of penguins, we might even have some folks in Antarctica. So today, I would like you to go to the website as we go along or at the end and go to rexandrewshow.com. And the reason I tell you to go there is because we put profiles of all of our guests up on the site. We're going to talk about a lot of things here today, but it's not always all the information. And so the people I interview and deal with are amazing people doing lots of things. And so we don't always get to cover all those topics. So stop by the website. You can find us on all the major social media platforms, and this episode will be streamed on YouTube. Okay, fantastic. Thank you for tuning in today. Well, life is, for me, I have too many interests for just one lifetime, but my biggest problem is around the corner, there's always another discovery. So today we've got another discovery for you, a great professional. And so I'm going to introduce you to our guest today. Most importantly, she's a wife and mother, in fact, mother of three little ones. And she's even got a really new one. So that's really fun. She is a doctorate of nurse practitioner in acute care. So has spent a lot of time in ICUs and acute care. She's done that not only just where she's locally at, but she's been a traveling nurse. So a lot of experience with that. And in addition to this, she's a podcaster. Great podcast. You got to take a listen to it. It's called Walking Home from the ICU. And so I'm excited to talk about today's guest and hear her story and what she's working on. So I'd like to welcome to the show, Kali Dayton. Kali, how are you this morning?
I'm great. Thank you so much for having me on.
Great to see you. Okay. So if you've listened in, which most people have, is what we do is like to tell people's stories a little bit. Okay. So how did you get to where you are? So we always go back and, kind of look at those formative years and where your influences are. So if you could, Kali, we're going to go back. We want to know where you were born. Where were you raised? Because that's not always the same. I've had one guest that moved 63 times before she was 15. Oh. So, she was the daughter of an international con man. So I don't think everybody quite fits in that category. Quite the story. But anyway, we're going to go back in time. We'd like to know about your siblings, your parents, what your parents did for a living, because that often influences us. Sometimes it's for good. Sometimes it's for other. We want to know about your interests growing up as a kid. Would you spend your time doing, what kind of person you were and those things. Then hopscotch through your education and stuff, and then up to what you're doing today, and really the topic of what we're talking about to spread some education on it today. So if you could, Kali, could you take us back to where you were born?
I was born in Caldwell, Idaho.
Okay.
But then at 7 years old, I moved to Spokane, Washington, and that's where I claim my origins.
Okay.
And that's where I spent the following years until I was 18. I then went to college back in Idaho to get my nursing degree in my undergraduate studies.
Okay.
Following that, I got my associate there in Idaho, and then I did a semester abroad in Jerusalem. And following that, I was a missionary in El Salvador and Belize for 18 months.
Okay.
And when I came back, I had my nursing license for 3 years, but no experience. And I miraculously landed a job in an ICU in Salt Lake City, Utah.
Okay.
And
No,
that's,
so let's unpack here a little bit.
yeah.
You're skipping up a little fast. How about siblings? I understand you have a few.
Yes, I come from a family of 7 kids. I'm the
Fantastic.
second oldest.
Second oldest, okay. And what did you do with your spare time? Second oldest, you probably were helping out mom a lot, but what did you do with your spare time? What type of interest did you have growing up?
Yeah, that's really how it was. My parents own a veterinary clinic. My dad's a
Okay.
veterinarian, and so I think there was a lot of caretaking throughout my childhood for my siblings. And but in my spare time, I was heavily involved in piano and music and theater. It was kind of my main gig. I tried every sport possible, but was no good at it. And when I discovered theater, I figured that was my groove. So that's
Okay.
kind of what I stuck to.
Fantastic. Okay. Now, is there a big range in difference with your siblings? You know, sometimes people have like almost like multiple families. They'll have some and then they'll wait a while, or
Yeah.
kind of stuff. So was it back to back, or what was the
There's a
makeup of your
19-year span.
19-year span? Okay.
And it's probably the biggest difference between my older brother and I. I think there's 6 years difference. And then
Okay.
after me, there's 18 months. And then
Okay.
after that is probably about every 18 months. So
Okay. All right. Well, I understand that. That's for sure. So, big family then. So how would you grow, how would you share with our audience your upbringing? I mean, did you have a typical upbringing? Was there stress? I mean, your father being a vet, running a clinic, I bet that was interesting. So what was family like for you?
It was pretty fun, but I don't even know what's normal, right? That was my normal.
Sure.
It was normal to have complete chaos and lots of noise and lots of stuff going on all the time. Um, and I think my parents, they bought this veterinary clinic when we moved from Idaho, and it was a big endeavor, and it took a lot of risk and a lot of effort to get it up and running. And so I think there were a lot of challenges and stress with that, but we definitely had to pull together as a family to stay afloat. And I think I feel like we were pretty normal as far as always people to play with, people to fight with, that we had our ups and downs, and we still do. And but it was a pretty good time. I think our house is kind of the party house. A lot of my friends wanted to come to my house because their houses were too quiet. So
okay.
And they were always put to chores and treated like part of the gang when they were at my house. So it was a good time.
Fantastic. Okay. So, okay, we'll skip back up. We got up with that. Skip back up. You got back and you got in your nursing degree. What was the next hop in your life?
Yeah, I feel like a lot of my adulthood has been focused on nursing. I always felt like I would end up in the ICU, even though I didn't do any clinicals or anything substantial in the ICU during my undergraduate studies. Granted, I did nursing school when I was 18, and so I could barely even tie my own shoes, and suddenly became a nurse at 19, and it was a lot. But again, I studied abroad for my bachelor's, and then I was a missionary and didn't do anything medical other than treating grown toenails and dengue.
Now, you were in South America, right, on your mission?
Correct. El Salvador and Belize.
Okay. Wow. All right.
And so that was a really impactful time of my life. And so I came back to the States really excited to be a nurse, and landed this job in the ICU in Salt Lake City. And I had no experience, and they were really kind to take me in and train me. And one of the questions that they asked when they were interviewing me, if I was okay or willing to walk patients on ventilators. And I was so naive and novice that I had no idea what that even meant.
Yeah.
And I said, yeah, I'm all about it. Absolutely. I was just excited about everything. And I had no idea the magnitude of that question, nor the impact that would have on the rest of my life and my career, to be able to be in that kind of atmosphere.
Okay. So you went to work with, they kind of threw the bomb over your head and you didn't even know what you were walking into, did you?
Nope, not a clue.
Okay. So obviously that's kind of something that's very important. So what did you discover when you started to experience this?
It was so normal. I didn't even understand how significant it was. I think in most other ICUs throughout the world, anytime someone's put on a ventilator, they're put into a drug-induced or medically induced coma.
Mm-hmm.
And I think that dates way back to the beginning of ventilators, when ventilators have been around since the early 1900s, but about like the 1960s, 1970s, they started being able to keep people on ventilators and keep them alive through ventilators for more than a few hours. And these ventilators were extremely archaic. They would just pound air in, pull it out, pound it in, pull it out. And it wasn't customizable. It couldn't sync with your own breaths. And it was very hard to ventilate people like this. And so they just started giving them the same medications that they give during surgery.
Oh my goodness.
Heavy sedatives, just to be able to synchronize the ventilator and essentially theoretically keep people more comfortable. That was the idea, because they look comfortable. They look like they're asleep. And since those early ventilators, our ventilators have become much more sophisticated. They have very sensitive sensors that can sense what breaths you're taking. You can program it to give them the right volume of breath at the right timing, the right volume of exhales and pressure, and it's just completely different. And yet, despite the evolution of ventilators, our sedation practices haven't really changed. Back in the 90s, we started being able to treat what's called acute respiratory distress syndrome, okay. ARDS, which can be when the lungs get really inflamed and kind of full of fluid after any kind of insult, usually from infection, but it can be lots of different things. So when the lungs get really, really sick, we can say it can be a long course. And back in the 90s, they started being able to keep people on ventilators and keep these patients alive that were just dying previous to that. And to do that, they started giving them deep, deep, deep sedation, lots of paralysis, so they would paralyze them, and give medications like benzodiazepines, so Ativan drips, the kind of medication that Xanax, a lot of anti-anxiety medications are benzodiazepines, but they'd give them continuously through their veins to keep them so deeply sedated. And then about a decade or so later, they started studying those patients and started noticing that their outcomes were really poor. The few that survived with incredible deficits. I mean, if you spend that long laying there, not moving a muscle, those muscles atrophy.
Yeah.
Every muscle in their body were atrophied. What they didn't know is that people were having terrors and hallucinations under sedation. They look like they're asleep.
Yeah.
The bed sheets are nice and tidy. The lines are all organized. Everything looks so cozy. And clearly the ventilator would be very uncomfortable. No one wants a tube down their throat. So we just all assumed that they were asleep and that it was more humane. Mm-hmm. But in researching survivors, they had what's called now ICU delirium. They were incredibly delirious and traumatized by those hallucinations, those terrors that we're having. And they described them as more vivid than reality. And they experienced the worst things. So if even today this occurs. And so I began to really sympathize with these survivors as I went to survivor pages and started talking to them about, I actually didn't even have to talk to them about it. I just was reading through their discussions amongst each other, trying to find answers and reconciliation to what they were experiencing months and years after discharge, why they were still having these terrible nightmares and why they were having these panic attacks and terrible symptoms of PTSD, all tying back to what they experienced under sedation. So back in the 90s, that wasn't known, nor did they really understand the cognitive impact it would have. So for whatever reason, the brains get severely damaged while under sedation. And now we have, decades of research that show us that there's a very strong correlation between sedation, usually during these medically induced comas because they're under such high doses and for so long. So sedation and cognitive deficits, or what we're now calling post-ICU dementia. So survivors are coming out of the ICU after having, a bad infection or different things, but their memory is severely impacted, like their short-term memory. They can't focus on things. They can't process. They can't do math. They can't read a clock. They can't, back in the day, fill out their checkbook. Tasks that are necessary for survival in a lot of ways, they suddenly cannot do. And I think the ICU community is in large part very unaware of this phenomenon that's now called post-ICU syndrome.
Okay.
Or we call it PICS. And so for whatever reason, it's not part of our training.
Okay.
To be aware of the repercussions of what we do. And so I started in this ICU where everyone's awake and walking on the ventilator.
Sure.
So I thought that was completely normal. That didn't faze me at all because that's the culture. No one makes a big deal out of it. It's just these patients are human. So we're going to treat them as human. They're going to be awake during the day, walk and move like humans do, and sleep at night. And so I was used to seeing people walk out of the ICU. I was used to hearing about them discharging straight home from the hospital. So after a few years in that, what I call the awake and walking ICU, I then became a travel nurse.
Okay.
And I went to different parts of the States, and I had a huge culture shock when I went to other ICUs. I mean, you walk onto these ICUs and the lights are dark and dim, pretty quiet except for some alarms.
Right.
And you pass by the rooms in the halls and patients are all in bed. Whereas in the wake and walking ICU during the day, the lights are up, call lights are going off. People are in their chairs by the bedside, even on the ventilator.
Sure.
A lot of them are on their phones, on their computers. It's just a much more human environment. And suddenly I'm in this dark place and it felt wrong. It felt weird. And I thought maybe it was just new to me. Anytime you're taken out of your normal environment, you can have a shock. But then I just started noticing that these people seem like bodies in the bed and like zombies, and I even clinical questions, like I felt like we couldn't assess their neurological statuses because they're comatose. And so one of the facilities I worked in, they said, oh, well, you give them vacation. So they would wean back the sedation, like start to decrease the dose being given until the patient starts moving all of their limbs. But they don't just move their limbs, they flail. They come out extremely agitated and wild. And then the people that taught me how to do these vacations said, see, they can't tolerate being off of sedation. So they failed the vacation and then we turn it back on. And I thought that is so weird because they were telling me that they can't tolerate the ventilator, but that didn't make sense to me because I had seen hundreds of people tolerate the ventilator.
Right.
So I was like, this agitation, this discomfort is not just from the ventilator. And I knew about delirium, but I just hadn't quite tied it all together. So I did that for a few years, and I would ask people, okay, can I wake this patient up? Because I would look at their diagnoses, their course, and I'm like, if they were in the awake and walking ICU, they would be awake and walking.
Right.
So I know that they don't need to be in this coma. So I just want to do my thing, what I am used to, like we always are inclined to do. So I'd ask doctors, nurses, hey, can I wake them up and get them up? And they would look at me like I was crazy. And they'd say, what do you mean? And one doctor asked me if I planned to follow them with an intubation cart, meaning his concern was that the breathing tube would fall out. And so he was asking, do I plan to like follow them with another breathing tube to put right back in if it comes out? Which the wake and walking ICU has never had someone's breathing tube come out while walking. They're secure to their face and their head.
Sure.
So it's so it was just kind of laughable, but I mean that's a valid concern. People are very worried about the breathing tube coming out, or the breathing tube, people pulling the breathing tube out. And so it was just, they weren't very productive conversations because I didn't understand their perspective and they could not fathom mine. And then so after a few years of doing travel nursing, I went back to Salt Lake and went to grad school. And still, the repercussions of these medically induced comas were not discussed. And in our case studies and our discussions, the assumption continued that anyone that's on a ventilator is going to get automatically sedated. They're automatically going to be put into these comas, even to the extent of having to put other medications on top of it because some of our favorite medications lower the blood pressure. And then sometimes they give medications to raise the blood pressure back up to compensate for that sedation.
My goodness.
And I actually lost it one time during a lecture when I was hearing this case study in such a scenario. And I looked around and no one was blinking an eye. It was just so normal. And I was full of a classroom full of people that work in the ICU, nurses that work in the ICU. And they're like, yep, that happens sometimes. That's just what we got to do. And I just kind of threw my hands down and said, that's crazy.
Mm-hmm.
That patient that you're talking about was just intubated. They weren't confused. They weren't agitated before. Why are they sedated? And they all looked at me like, what planet are you on? Like, do you not work in the ICU? Are you not an ICU nurse? Of course they're sedated because they're intubated. That's just what we do. And again, the assumption is that it's more humane. When in discussing those people in the ICU community, they always say to me, oh, no. If I was on a ventilator, I would have to be sedated. I would want to be sedated. I don't want to feel that breathing tube. It's so uncomfortable. And, I think that mentality comes from what they see when they take down sedation, meaning when they wean it off, when they turn it off and patients come or wake up, because you can just see the terror in their eyes. They come out, like I said, kicking, flailing. We call it a rodeo. And they automatically go for the tube because they want that thing out. And talking with survivors, a lot of times they didn't even know what was in their throat. No, they almost never knew what was in their throat, just that it was uncomfortable. Yeah. But they're agitated, they're flailing because for the days to weeks under sedation, they were thinking that their kids were kidnapped. They thought they were kidnapped. They thought they were in enemy territory. And they misinterpreted everything they heard and smelt, sensed while in the ICU. So they thought the chest tube were gunshots. They thought the temperature probe checking their temperature every 2 hours was a gun being put to their forehead. And they'd hear a click and then assume that there were no bullets in the gun. Right. And so the just sheer terror of bracing yourself, thinking your brains are going to be blown out, was so real to them. And so when they come out and they can finally move their extremities and they're more connected to their environment, they're still stuck in their delusions.
Okay. So I want to pause there for a second.
Yeah.
I'm tracking with you. Not that I'm a doctor or anything, but I understand a lot of that because I've got a lot of that around. When we use the anesthesias in general medicine to put people out for surgeries, is that the same type of anesthesia and medication that's being used to take people into these medicated created comas?
Usually.
Okay.
So I mentioned the Benzodiazepines, this class of medication that's can be used for anxiety and also used for sedatives. When we saw how horrifically they damage people, there was this big movement to avoid them.
Okay.
So in a lot of more progressive hospitals that are more current with the research and practicing evidence-based medicine, they really try to avoid benzodiazepines. And yet there are other sedatives that we use that are also used in surgery. So generally, yes, they're either the same medications or the same class of medications.
Okay.
Often at very similar doses. So I think that's another problem where those of us in the ICU, maybe we've had simple little surgeries or big surgeries, and we come out and we're like, good thing I didn't remember a thing, right? No one wants to be awake during surgery. That is a very appropriate use of sedation.
Yeah.
And so we relate our experiences under anesthesia during surgery to what our patients are experiencing. But there's a huge difference in what they experience for a few hours versus a few days or a few weeks or a few months.
Yeah, that was the next place I was going to ask you. Obviously, anesthesia has been used for forever, for as long as they've been around, for a long, long time, for decades,
right,
to help people get through surgeries. I've been through a couple minor surgeries. It's a wonderful delight not to remember any of that stuff, right?
Absolutely.
But so are there studies or there information or is there research going on to say, okay, because it you know how it is in life, too much of anything's a bad thing, right? It just is. And it sounds like there's sort of there's an old adage that says if the only tool you have is a hammer, then everything looks like a nail. So it sounds like these anesthesias are, okay, that's the way to put somebody on control so they're not in pain, they're not fighting that tube. But it sounds like they're using the hammer on everything. They're doing it. So I guess that's a long-winded way to get around to where is the safe zone amount of time, hours, and where does it become very, very dangerous and permanent damage type thing?
So I guess my approach is we cannot optimize care if we don't personalize it.
Sure.
So there are situations in which sedation is actually essential, like essential for survival.
Mm-hmm.
Some of these ARDS patients, when the lungs get so sick and their ventilator settings are maxed out, they're getting as much support from the ventilator as possible, and yet they're still not able to oxygenate.
Mm-hmm.
And then their lungs are so stiff that they're not synchronizing with the ventilator. Then it can be questionably beneficial to paralyze the patients. And that's when we deeply sedate them so that they're not locked into their bodies, right, while they're fully awake.
Right.
That's an exception when people are having seizures, if they have an open abdomen, some severe drug toxicity. So you get some of these like meth or bath salts, these severe drugs, and these people are extremely dangerous.
Mm-hmm.
So there are exceptions for sedation. It's not across the board that sedation should never be used.
Sure.
The approach in the wake and walking ICU is we treat it kind of like for procedures. So putting the breathing tube down someone's throat is a procedure.
Yeah.
So we sedate them for that. We give a quick bolus or like just one time or a few times of that medication,
Mm-hmm.
and then allow them to wake right back up.
Okay.
And so they've been out for maybe like 20-30 minutes.
Right.
And then when they wake up, it's like waking up from a little procedure, but they have the breathing tube down their throats. So we remind them of what they knew or what we discussed 20 minutes later. They do have their hands tied down just because they can come out a little bit confused, and it is uncomfortable, and it's a huge adjustment. So we'll tie their hands down, but just explain to them, and we really try to have the family at the bedside and
Sure.
calm them down with all these other ways. And so almost everybody, and this is a medical surgical ICU. So everybody with these infections, respiratory problems, post-surgical, a lot, it has a huge range of different patients that we're treating. Almost everyone is allowed to wake up right after sedation, right after intubation. So as soon as they have the breathing tube in, they're awake.
Yeah.
And the key to that is that it prevents delirium. It makes it so they never get so crazy and agitated and confused, and people are able to keep their right minds.
Okay.
And so that's a really different approach. I think most ICUs around the world sedate for the procedure of putting the breathing tube down. And then while these patients are still, quote unquote, asleep or sedated,
right.
There's a huge difference, but we use that word asleep, and it's kind of a trigger for me because it's not sleep. But then they start these drips, these continuous IV drips of sedation, so that the patients will never wake up until they feel like it's time to wake them up, whether it's by ventilator settings or all the other problems that are going on. And once they're fixed, then they'll let them start to wake up. But by then the damage has already been done. So I think we're finding that it's a lot easier to not start the continuous sedation and to never let patients get delirious. It's not always 100% preventable because lots of things can make people confused and kind of crazy in the ICU, but it is so much easier. And I think people get really scared about ventilator settings, like if they're needing a lot of support from the ventilator. But we have seen incredible outcomes and a difference when we continue to get people up and moving while they're on even higher settings on the ventilator.
Mm-hmm.
So our threshold, or the threshold in the wake and walking ICU, is definitely different than probably any other ICU in the world. But there's never been adverse events or outcomes because of that. If nothing else, there's been a huge benefit, and we have data supporting that I can discuss.
Okay, so the awake and walking ICU, how old of a strategy is this? Is this something relatively new? Because obviously it's easy to understand. I mean, heck, we've been putting people in medical comas for a long time, heavy sedation. Okay, we get that. So how new is the waking and walking ICU?
So one of the most exciting yet discouraging parts is that this ICU has been doing this approach for almost 30 years.
Oh, wow.
So this all started pretty much back in the 90s. My former colleague, Polly Bailey. She's now a nurse practitioner, but she was working in a trauma ICU there in Salt Lake. And this is when ARDS was becoming a very treatable thing. And she followed one of the survivors of her ICU out to their home. It was a woman from her own community. And she, back then, the nurses would kind of be the primary nurse. They would follow them throughout their hospitalization. And she just got attached and followed her even home. And she noticed this young mother in her 30s took almost a year to be able to go up the stairs. This is before they had rehabilitation centers. And so they were literally lifting people from the stretchers into their cars and saying, good luck. So her husband was having to toilet her, like use the bedpan with her in the bed. She was extremely fatigued and she had horrific PTSD. And this is the first time Polly had really been exposed to life after the ICU, and it haunted her. And Polly is extremely compassionate, and it just wouldn't leave her. And she went back to her medical director, who was Terry Klimmer at the time. And he's interviewed in my podcast in episode 2. He's one of the founders of critical care, and he is a visionary. But she said, Dr. Klimmer, we are breaking people. We cannot let them get so deconditioned, so weak to this point. But what can we do? And he's like, I don't know. And she said, let me keep them moving on the ventilator. If we kept them moving, wouldn't they be able to stay strong, or at least strong enough to keep walking?
Yeah.
And that was a scary prospect. There was no research, no data on it. No one else had ever done it. And Dr. Klimmer says he was really doubtful and a little nervous about it, but he trusted nurses and he trusted nurses' intuition. So he let Polly experiment with this.
Okay.
So she started taking off sedation off of people and getting them up while they were on the ventilator, even during their critical illness. And it changed the outcomes. They weren't nearly as delirious. They were able to get the breathing tube out faster. They were able to go home and resume their lives better. I mean, it just started to change. And so they really tried to standardize that for everyone on the unit. But it's a hard culture to change. It's actually really convenient to sedate people.
Yeah.
You don't have any call lights going off. You don't have to talk to people. Some people get into ICU because they want to not talk to people. I don't think that's the standard, especially now. I think ICU people are some of the most compassionate and competent people out there. But there was a lot of just fear, I think, as well, that it's scary to have someone awake. Are they going to pull the breathing tube out? It's scary to walk them. Is the breathing tube going to fall out? So they met a lot of those challenges in standardizing this or making this the norm. So they ended up starting their own respiratory ICU. And Polly kind of was able to spearhead and create this new culture. And they hired nurses from nursing homes and rehabilitation centers that were developed at the time, who were comfortable and used to walking patients, who didn't have this ICU culture stuck in them. And they said, hey, here's what we're going to do. We're just going to keep people awake and walk them. And they said, okay, great. And so that became the standard and the norm. And so here we are 30 years later and
now,
still doing it.
Is it widely adapted yet?
There are different degrees of approaches and compliance with this kind of method. So we have Polly put out a study back in 2007. They studied those patients and they showed that it was safe and feasible to walk patients with acute respiratory failure or patients that need to be on the ventilator in the ICU. It's safe and feasible to walk them during that stage of their illness. So that was in 2007. And that kind of spurred on, that got a lot of attention from the medical field, right? From these researchers. Sure. And so they started studying and really capturing the damage that's done, the post-ICU dementia, the post-ICU PTSD, the muscular weakness, all the things. And so everyone wanted to change that, right? And they started doing more studies on delirium, what happens to the brain. And then when people develop delirium, how does that impact the rest of their lives? And so one of the big researchers was Dr. Wes Ely, who I also have in the podcast. And he developed a protocol called the A to F bundle, where you give these sedation vacations and see if people can be, they can breathe on their own, if they can be awake, if they can tolerate. And so there's been this big movement to try to shorten the duration of sedation, shorten the dose of sedation, change the kind of sedatives that we give. So there's increasing awareness, and there's also lots of talk about early mobility. And so every facility has a different culture. So even within the same city, I've seen, there's an awake and walking ICU, and then there's a neighboring hospital where there's no way you're going to open your eyes on a ventilator. And within that same hospital, they will walk on ECMO, which is an even more invasive intervention. It's like a bypass machine. They'll walk on this bypass machine, and yet down the hall, they won't dare move a muscle on the ventilator. And then across the city, they'll give sedation vacations and maybe walk some excessive patients. So I guess that's where I feel really passionately, is that the public should know how different their outcomes are. And we can talk about how much this impacts outcomes if you'd like.
Yeah, just a sec. So is it, would you just anecdotally guess, is it 50-50? Is it 20-30? I mean, what percentage of patients are getting sort of the waking and walking strategy versus traditional?
So on my Instagram page, I would say my followers are predominantly in the medical field and ICU.
Sure.
I ask questions just to get a feel. I mean, this isn't anything official.
Yeah, anecdotal. We'll take it. Yeah.
Yep. And I've asked, do you automatically sedate your patients at the moment that they're intubated? And 87% said yes. So I would guess about that many, maybe some less, are not moving on the ventilator. Even there's this wonderful study done on the A to F bundle, or the A, B, C, D, E, F bundle, where it involved 15,000 patients. It was done back in 2019, and I'm pretty sure it was international. And so all of these units are trying to shorten the duration of sedation, give vacations, see how soon they can get the sedation off.
Yeah.
So it showed awesome outcomes. And when I looked at the mobility part of it, how many of these patients were actually getting up? 5% were taking steps in the hall, 7% were standing at the bedside. So only 12% of those 15,000 patients were actually putting weight on their feet, were actually standing up on their own.
Having some circulation. Gosh, I mean.
Well, and just, so the culture in the intensive care world is that most, if not, I mean, some units I've been told by travel nurses. One nurse came from Mississippi, and he told me the medications that they give, and they're severe benzodiazepines, which a lot of units have gone back to in the COVID era, but this is pre-COVID, and I just was appalled that anyone would be using these certain medications. He said, everyone gets first sed, and then everyone gets trached and pegged, meaning they get a tracheostomy and a feeding tube placement, because they're going to be too weak to hold their own head up or to take their own breaths. We use muscles to breathe.
Yeah.
So when people are on ventilators for a long, long time, it's often because not their lungs are so sick. It's because they don't have the muscles to breathe anymore. So then the ICU kind of says, well, we fixed the problem. The infection's gone, or whatever is causing them to be on the ventilator, but now they can't breathe on their own. So they're going to have it for a lot longer. Let's just, sounds horrific, but just cut a hole through their throat, put a more secured airway in, and then send them to rehabilitation, and they can kind of fix the muscular atrophy that we caused. Whereas in the wake and walking ICU, I can count on two hands, but not all the fingers, the times and the years that I spent there, how many tracheostomies were performed on patients.
Yeah.
And they were for incredible exceptions like muscular dystrophy.
Yeah.
It was not because of poor care. It wasn't because they atrophied, or a preventable atrophy.
Yeah.
And so that's a big pet peeve of mine, is that, and again, it's just so normal that I think we're all inclined to be that way. We are a product of our environment. If we know, if it's the only thing that's ever done, the only thing we've ever known, why would we question it?
That's crazy. So I'm sitting here thinking as a parent, I'm going to send my kids off, or any family members off to a hospital. And I know this could be something serious. That might be one of the first questions I'm going to ask is, what is your, in ICU, what is your strategy as far as, taking care of patients when they need to be sedated, or, what's the strategy here? Gosh, that's scary.
Absolutely. And on a personal note, I have a daughter with a neuromuscular disorder, and she's 2 years old, and she is still working on things like sitting up and head control. So her muscles really are not exceptionally functional. And so she got the rhinovirus, or just a normal kid cold, back in October. And which isn't usually a big deal, but it became a really big deal when you have a lot of mucus and secretions in a kid that can't take deep breath and cough really hard and isn't up running around moving that mucus out, right? Which is also another benefit to walking in a ventilator. We move the mucus out, right? But that she could not do this on her own. And so very quickly, within hours, she became in big trouble. So here I am running into the ER with her in my arms. Sorry, I get emotional. And I am an ICU nurse practitioner, but I only do adults.
Yeah.
But I knew what this could mean. And I didn't know what they did with kids.
Right.
And my daughter is cognitively intact. I mean, she's probably at least at level with her developmental age. And so we were in the ICU or in the ER, and I'm looking at these doctors in the eyes, and I can tell that they're worried. And I know that they're thinking about a ventilator and trying to decide whether or not to intubate her, to put her on a ventilator.
Right.
That was my first question. Do you deeply sedate your children? Because I didn't know any of the studies about children, but I had a moment of panic trying to imagine my daughter having that kind of terror, hallucinations, nightmares, having her in that kind of isolation. Even adult survivors talk about how lonely and isolated they were while in these comas. She has such a great personality, but even adults come out with this PTSD that changes them.
Yeah.
And her cognitive function is the most functional part of her. And would she come out with this post-ICU dementia? Would we hinder her brain? Would we damage her brain?
Right.
And so I was panicked, and I didn't know what people did. And so I have some upcoming episodes, because I went out and I hunted down some top researchers and clinicians in the pediatric world. And there's a huge movement to stop doing the same thing to kids, and because we break them just as bad. And so this hospital was a little more open to not sedating her. And also, I mean, part of the reason we sedate is we were afraid that they're going to pull out the tube. And I said, look at her. She's not going to pull out the tube. She's too weak.
Yeah.
And so I was grateful that they were open to discussing it. And I feel like if the public knew what the options are, what the possibilities are, and what the repercussions of these treatments were, they would be the strongest advocates. And so I'm actually starting a consulting service that we can talk about later. But I feel like patients' families can be a huge turning point in our culture in the ICU.
Okay. So what are the big differences in outcome? I mean, I'm just sitting here thinking about this as just, being that heavily medicated for lengths of time. It can't be, I can imagine the list of things that damages is as long as your arm.
Yep. And as much as I've been studying this, I keep on finding out more things that it damages. Okay. So research shows, there's so much research that shows that there is a direct correlation between sedation length and depth to post-ICU PTSD, post-ICU dementia, and then things like readmission to the ICU.
Right.
So the more sedation that we give, the more likely they are to be readmitted to the hospital and the ICU later. Likely because when they don't move for that long, they get these tracheostomies and feeding tubes, and they go into care centers. And LTACs, long-term acute care hospitals, generally are not well staffed. I've heard of 20 patients on ventilators to one nurse.
Wow.
And not a ton of physical therapists. So the rehabilitation process can be very poor. When you're laying in bed and you're in a care facility, you're at higher risk of having an infection. So I'm sure part of that is because these patients are shipped out in terrible condition and then do not receive aggressive, adequate care, and then get new infections that require ICU stays or hospitalization again. They're also, the more sedation you give, the far less likely they are to discharge home. So in the wake and walking ICU, they looked at some data of outcomes. And it's not that we can't do a lot of research there because there isn't a control group. Knowing what we know, I mean, who's going to sign up to be the control group? Who's going to sign up to get the sedation? Knowing that it's harmful, it's just not ethically sound. We cannot go back. We can't change our practices that we know are saving lives. And so we looked at an outside hospital, a neighboring hospital, and we compared patients. And there's a way to kind of rank how sick people are. It's called an Apache score. So we looked at patients at the same Apache score and then looked at their outcomes, or we looked at how much sedation they got.
Right.
And then looked at what percentage of patients from the awake and walking ICU discharged straight home from the hospital versus patients from this outside hospital. Mm-hmm. So almost 98% of the survivors from the awake and walking ICU walked out the hospital doors, got in their cars, and went straight home.
Wow.
46% at the outside hospital were able to go home, meaning 54% probably went to rehabilitation, LTACs, those kind of facilities, nursing homes. Mm-hmm. Because they were unable to go back to where they came from because they were so deconditioned and broken.
Wow. That's crazy.
It's really disheartening. And so,
I would just, sorry to interrupt. I would just guess that 99.9% of the families that when someone's this injured or needs this type of acute care have no idea even to ask these questions because.
Oh, absolutely not.
See, I don't carry it on my sleeve or anything, but I'm bipolar. When I was diagnosed 20 some years ago, it was bipolar 2 hypomania ADD. So basically I just have a really bad chemical mix in my brain, right? And fast forward to today, the DSM's been changed, right? And that stuff. So now I'm bipolar undefined because they can't figure out really because I don't fit a lot of the characteristics that are normally there. But I've done so much research on my own, mostly anecdotal research. It's not like I'm a lab rat or something. But brain chemistry is brain chemistry. And if I have been on 11 different combinations of medications for my bipolar. When I first got it, it was just, throw meds at it. We'll see you in 6 weeks for a therapy session here and there. And we'll just keep throwing meds at it. Well, the side effects and the downsides of all those meds, being medicated up to be down, up, down, and up and stuff, it was a yo-yo. And finally, I just can't do any more of those types of things. And I started to look at more exhaustive care. So I just completely resonate with this because you're seriously messing with the nervous system by putting these, anesthesia type of medications in there for extended time. I wouldn't even be surprised there's things like neuropathy and all kinds of
absolutely
issues because it's just permanent nerve damage. You're just dulling the body.
There's nerve damage, there's muscle damage. So the muscles atrophy, but it's not like you can just jump back into the gym and rebuild those muscles. For some reason, the ability to rebuild those muscles is severely impaired. Uh-huh. And some people continue to have more muscle loss after the ICU. And one of the big risk factors to post-ICU PTSD is baseline psychiatric disorders.
Oh, yeah.
And so I during my my graduate studies for my big final project or dissertation, whatever you want to call it, I created a post-ICU PTSD screening tool, and I presented it to a corporation or a hospital that takes care of a lot of military personnel. And so I tried to explain these people have been to war. They likely have high rates of PTSD. The last thing they need is to be in medically induced comas. And I was just kind of scoffed at. They said, so as soon as, and they're like, we'll talk about PTSD, but as soon as you try to touch our sedation, you're out. And they kind of put up with me just for the project. They kind of went along and used the tool. And, but that was my first exposure to, I knew that the culture would be hard to change, but just how quickly they shut me down. But I think that's a huge discussion. I had a patient that was delirious. She had been at an outside facility, another hospital, had been sedated, but she was also in alcohol withdrawal and had an infection. So she had all these really bad risk factors for getting super delirious. And when she came to us, she'd been kind of written off at this other hospital. Just that her lungs were so sick and she was just going to die. So she came to us, and when we took off the sedation, she was extremely confused and agitated. And the inclination is just turn the sedation back on because they're so hard to handle. I can't even describe These people are trying to pull out their tubes. They're trying to get out of bed. It is stressful. It's dangerous. It is so difficult. But part of the discussion was that this patient had a history of PTSD. She had a history of depression. That's why she was, on alcohol and Xanax and all these medications.
Sure.
So instead of saying, oh, she's too crazy or she's going to be too delirious, that was part of our focus. We were looking at the big picture. Is it worth it in this moment to sign her up for post-ICU PTSD? And she's had trauma and abuse. She's probably reliving that in her mind right now. Like, that's part of our discussion. And it changes your compassion and your patience and your preservation, your endurance during those situations when you know that not turning back to sedation and working hard and using all these other approaches to try to keep them safe while they're coming out of delirium. When they understand the why, then they're more willing to do it. The problem is in our ICUs, there's no discussion like that usually. Because most of the ICU community is completely unaware. If the patient looks more comfortable, meaning if they're not moving a muscle, if they're lifeless and still, then they probably are more comfortable, is the kind of shared mentality.
So is it a matter of just ease of care? I mean, it sounds like it. I mean, I'm a layman, okay? I don't know anything about this stuff, but if I have to choose between having to really actually work with someone and help them, come in and out of things, or I just, sedate them and let them be there. I mean, it almost sounds like I don't want to be accusatory or anything, but it's almost like lazy medicine. I mean, are we just doing this because it's the easier way to manage the patient?
I think it totally depends on the team.
Okay.
I think that's one of the barriers. We've gotten very used to it. I mean, there are jokes about like, man, I hope I have an intubated, sedated patient today, because that makes for a quiet shift.
Yeah, quiet shift. Yeah, nobody's hitting the call button on that one.
Right, and so and then by the time you take sedation off, they're too weak to use a call button.
Yeah,
fun, but that's so. So I think that again, I really feel like people that have that expectation and preference, they don't understand what that means for patients. So it's not like they're willing to sacrifice their life or their quality of life for a quiet shift. They just think that, hey, it's better for the patient, better for me, win-win, right?
Right.
There is a problem, when people have been on sedation and then you take it off, they're agitated and then it's so much work. So yeah, there's a lot of valid frustration. It's saying, when we have these staffing problems, especially during COVID, nurses should be 2 to 1 in an ICU. And during COVID, they've been up to 7, even I've heard of 13 patients to 1 nurse. So how can they keep patients safe?
Yeah, that's crazy.
When they're confused, delirious, agitated, and trying to pull out their breathing tube. So as far as work-wise, I try to help the ICU community capture the vision, because in the wake and walk-in ICU, their delirium rates are pretty low. Because normally when patients just wake up right after intubation, they're not delirious. And so they protect their breathing tube. They cooperate. They can get themselves out of bed. When we get people up right after they get the breathing tube placed, like within hours. Because if you stop walking, I tell patients, you stay in bed, that's where you'll stay. So It is so much easier to have someone start walking on the ventilator right after they get put on the ventilator, so that they never lose the ability to put their own feet out of the bed, stand up, walk. That is so much easier to do. It doesn't take nearly as many people to assist. Someone that's been in the bed for weeks, then you have to have special lifts on the ceiling or special equipment to help lift up this flaccid adult body. And then it's just so dangerous and hard when someone can't even bear their own weight on their legs. And so then it takes 5, 6 plus people and lots of equipment to rehabilitate these people. And so, yes, people hear these approaches and they're like, we don't have the staff for it. We don't have the equipment for it. But I think if we change the sedation practices, it wouldn't be as laborious as we anticipate.
Interesting. Well, this all makes sense, because I think back, my mother had an accident as a young lady with a horse, and it ended up causing hip damage and stuff. And so she had, I don't know, it's probably been 20 years ago since she had a hip replaced. Okay. Well, back then you had a hip replaced, they didn't have you out of bed forever and that kinds of stuff. You have a hip replacement now, they got you up within a few hours after, it's been replaced. They're working with you. They got you in PT, they're working on getting you healed again, because your body isn't going to respond if you're just laying there. Your muscles are needed to create the help of circulation, to keep your blood moving. Obviously, again, I'm not a doctor. These just
no, you are. You bring up a very important point. It is so much of it is cultural.
Yeah.
Women after childbirth would be on bed rest for weeks, and then they started noticing, wow, they're getting pneumonia, they're getting blood clots. It's probably harder to take care of your kids once you get that weak. And so now we look back at that and we raise our eyebrows and can't even believe that was a thing.
Yeah.
Post surgeries as well. We look back and we're like, wow, why did we think the worst thing possible was appropriate for these patients? And if I had a crystal ball, at least in my own dream world,
right,
this is the future of critical care. Someday we will look back at all of these medically induced comas that we automatically put patients in, and we will shudder.
Yeah.
We will say, why did we ever do that? So that's why I started the podcast, because I felt like my vision will never come to fruition if the ICU doesn't know. But as I started teaching and talking with the ICU world and really speaking out, I kept feeling like the public deserves to know as well. I feel like it's our dirty little secret. And how different their outcomes could be if someone said at the very beginning, the moment someone's intubated, let's stop and think about this. Let's just let them wake up. And as a family member, I would say I will be there at their bedside. I don't care if they're batshit crazy. I will hold their hand for the next 2 weeks straight if that means that I get to bring home the same person that I brought here.
All right. Well, there's the other whole side of this, and I'm not trying to be callous or anything, because I've been accused of having a stone heart, which is not true. But if you look at the economics of this is insane. I mean, keeping someone sedated for weeks or months type of thing, the cost on that, what do they say about 1 out of 3 bankruptcies now is from medically created bankruptcy?
Yes.
It will completely drain somebody to have them deeply sedated for weeks, months, whatever it happens to be, when the better care and better common sense is just, wow, why don't we do like what they're doing now with like a hip replacement? You're up and they're moving, you're getting your rehab, you're getting your body working, because the human body is amazing. It will self-care and repair itself. So it's an amazing gift from the Lord. It's an amazing gift. And so what you're talking about is it makes so much sense. And I'm almost outraged at the fact that, I know nothing about it. I'm not immersed in it like you are. But boy, I tell you this, anybody goes in the hospital, the first thing I'd be asking them is, what is your sedation strategy, and what do you do when you're getting them out?
I don't think that's callous at all. I'm about to do an episode on that. The money side of it.
Oh, the money side's crazy.
We have studies showing that hospitalization costs drastically decrease as we decrease sedation and we increase mobility. And so it is just, I'm going to formulate the most incredible presentation that people can just plug into their administrations, because it's got to be so much cheaper to hire more nurses, or physical therapists, techs, aides. I mean, an aide that can help push an IV pole, push a wheelchair while people are walking, and it can make the biggest difference. So the less sedation we use, the quicker people get off the ventilator and out of the hospital. And then we can prevent transfers to rehabilitation, nursing homes, long-term care facilities. So it's got to save millions of dollars. I mean, just incredible financial benefits. But that's not the way administration sees it. So they cut their staff to the bare bones.
Yep.
And overload them, and that makes implementing this process really difficult, when really financially it would make a huge impact to have patients get good care and have good outcomes and get out of the hospital, and not have to. So I think that's very compassionate to not want to bankrupt people, to not want to deprive their ability to go back to work. I just heard on a podcast, COVID patients. They've studied COVID patients a year after discharge from the ICU. 50% are still not able to return back to work. 50%. And these are people that were working before. I think people assumed that COVID has only been bad for the elderly.
Right.
Which is a whole nother thing. But I was seeing people in their 30s and 40s who were panicked about losing their jobs and missing work in that moment. And I said, hang in tight, work hard so you can go back to your job.
Right.
But I don't know if we really think about that. But if we sedate people and they have cognitive deficits, people can't go back to their careers if
Yeah.
they can't read a clock. If they can't think straight, they cannot resume their jobs. So sometimes they'll resume their jobs and then they lose them because they're not functional anymore. And so we deeply impact them financially, which impacts their mental health, their family. Like this is huge. And I also worry because a lot of our COVID patients were minorities, immigrants. I treat a lot of people that probably do like need their bodies to keep their families alive, to provide for their families. And so when we deeply sedate them and they may never be able to go back to the work they were doing, who takes care of them and then their family? And the disability rates are going to be huge. And so there's another study that came out looking at, and this was done by Dr. Wes Ely, the delirium expert, as well as Brenda Pun, big researchers, and they looked at, I think, 13 different countries with COVID patients and looked at what they were doing, how they were treating them. And 60% of those patients were receiving continuous benzodiazepines, meaning they were on the worst kind of continuous sedatives.
Oh my goodness.
So I don't know why, other than we panicked, we've had staffing shortages, it's been a mess. But with COVID, we've gone back to the worst practices from the 90s that we knew were lethal to people. All of this, medically induced comas, increase your mortality rates. And so I asked in my podcast, it's been very cathartic to reach out to the medical community and ask questions like, when you're telling the families that you're doing everything possible to save their lives, are you telling the truth if you're putting patients in a medically induced coma when it's not actually essential? Because that increases their chances of dying in the ICU or after the ICU. No one's really asking those hard questions, and I can't sleep until I ask them and get answers.
I get it. Well, and it's a whole nother discussion about the economics of our medical and healthcare system.
Absolutely.
And when we add in the insurance companies, the hospitals, the doctors, all the layers, and it's quite a complex mess. And it's never as simple as the politicians want to make it out to be. But the economics are crazy. 40 some years ago, there was a Democratic governor here in Colorado by the name of Richard Lamb, and they called him Dick Lamb, but he was always about preventive care, not corrective care, because we cannot continue to support corrective care. And this is mind-boggling. And, to see us slide back into these really bad strategies because of COVID. Essentially when I talk to front care workers during COVID, it's like, well, look, if you got on a ventilator, your choices were not very good. Okay. Your outcomes were not going to be very good if you got on a ventilator. So here's
the thing on that too. I think part of the reason comas increase your chances of dying is I just did an episode with a researcher that explained that when muscles atrophy, when they break down, they trigger an inflammatory response. So they release these cytokines and these inflammatory markers that make the body basically, I don't know how to put it in layman's terms, but kind of explode from the inside out. So COVID's already causing this huge inflammation in the body, and when the muscles atrophy, it causes more. And so we are almost we're like, okay, that's a really bad disease, this is a lethal disease, and we give them lethal treatment. What can we expect?
Right.
Whereas I think the Wake and Walking ICU, I had heard they discharged maybe one person to a nursing home or an LTAC out of their COVID ICU. Everyone else has gone straight home. Their mortality rates have been drastically different. They've had to do a tracheostomy on one person that had another fibrotic lung disorder on top of COVID. And so their outcomes have been completely different. And within the same city, outcomes are completely different. So I started a consulting service so that family members or even patients that are in the ICU and have questions about this and want to know, want to brainstorm and talk about how to advocate for this and when would be an appropriate time to sedate or not sedate. Along with the ICU team, I if I'm not there, I can't make any decisions for anyone, but I am happy to be a resource for patients and their loved ones and help them advocate and almost demand this kind of process and outcomes for those that are in the ICU.
Now, do you have a website for that yet, or are you run on a Facebook group, or what do you have?
The website will come out hopefully in a month.
Okay.
It's www.criticalcareconsultant.net.
Okay. Fantastic. And then you do have a Facebook group, right, for this right now?
For the podcast, I do.
For the podcast, yeah.
So you can look up Walking Home from the ICU on Facebook.
Okay.
There's also a discussion group for healthcare providers. I'm also on Instagram and Twitter under the same handles.
Well, I tell you, after learning this from you, I'm going to get behind your cause and help you get the word out, because I can't even, I mean, the difference of outcomes are literally life and death. And in my opinion, just sitting here listening, again, is 100% layman. Basically, if you're kept in a sedation state that long, you're just basically, it's almost like a chemical lobotomy. It really is.
Wow, that's a great, I might actually steal that.
You're welcome to take it.
Linguistics there. Yep.
It's a clinical lobotomy, because I study all brain health all the time, because that's, in order for me to function like a normal person and not have issues and all kinds of stuff, I got to be paying attention to what I'm putting in my body and those types of stuff. And then,
and the problem is we have lots of markers to gauge the function and the health and the status of a lot of our organs.
Yeah.
We love tracking the kidneys, the liver.
Because you can examine all that, right? I mean, it's right there.
It's numerical.
Yeah.
But we can't, there's no number or reading or lab that we can draw for the brain. But delirium is a sign of brain injury.
Yeah.
But I think that's not a shared mentality. So when I see delirium, I'm like, oh no, something's happened to their brain. Their brain's sick. We have to resuscitate their brain. We have to preserve their brain. If someone has kidney injury, I'm not going to give toxic medications that hurt the kidneys. But when people are confused and delirious, we give neurotoxic medications instead of saying we have to avoid those because their brain obviously has been injured. We injure it more.
It's interesting. Just listening to this, I get on a soapbox, and again, I'm not a medical person. I'm just a guy who does a lot of reading, but with somebody who has brain chemistry issues. I believe that brain chemistry is as individual as your fingerprints. Okay, it has to be. When you think of what different chemicals and different things we have in our bodies, levels of dopamine, serotonin, all of those things, we contribute to a brain chemistry. And I've always had this wish that someone could come up with a brain chemistry evaluation test that when I walk into a hospital, I can basically say, well, this is my last reading on my brain chemistry makeup, Yeah. Here's my roadmap, or my percentages, whatever you want to call the thing. And then they can actually help me with care based on that, because your brain runs everything. I mean, that's not a genius insight, but I really think, and I say this all the time, not just because I got you on the show today, I think the biggest advancements we have in medical health is in brain health. I really do. And if someone could come in and figure out how to get this, basically a snapshot of your brain chemistry, it could also dictate your personal care, because you just, to me, this just sounds like lazy medicine. Well, okay, so this is what we've seen in the past, so we're going to swat flies with an atom bomb, and we're just going to treat everybody the same way. Well, it's never the same way. You're talking, to me, I get on a soapbox. I've been on 11 different combinations of medicine. None of them worked. None of them worked exactly right. It was trading it was trading other types of side effects for each combination. And it's just like, okay, how come you can pull my blood panels? How come you can't just get some information on my blood that says, here is Rex's brain makeup, and these are the things he should be doing to do this. And that would also help us. I mean, if you could do that, that would help us so much in being able to help treat people on an individualized basis. Because when you have a major trauma that requires sedation like this, we're talking about everything. I mean, it's a system-wide failure.
Oh, no, it's brain failure. I mean, I think in the ICU, we can greatly neglect the brain. And that's what makes us human. Yeah. The brain is what makes us human. And it just breaks my heart to hear survivors say, I lost me.
Well, yeah, it's like coming home an Alzheimer's patient. You're a chemical Alzheimer's patient. I'm just.
And we don't warn them. We don't tell them. We don't say, hey, you had delirium during your stay, or you might be at risk, or you might have these symptoms. We don't refer them to cognitive therapy or psychiatric support after their discharge, in large part because the critical care community is unaware of what life is like after the ICU. And so I have lots of requests of the ICU community, but I also have lots of invitations for the public. I think we do informed consents prior to surgery, all sorts of procedures.
Sure.
We explain the risks and the benefits and what could happen, what may, all sorts of things, but not a word is said about these life-altering impacts of sedation. And we don't give people the option.
Wow, that's crazy.
So can it really be an informed consent if we're not informing them? So I'm asking the medical community this question, but I also want the public to know that they may have an option. I mean, I think the moments in which medical-induced comas are actually essential are the minority. So it's worth discussing. And you can't weigh risk versus benefits if you don't know the risks.
No, you can't.
Everyone should know the risks and know, and again, and this can all be dose dependent. Maybe you need sedation for a few days, but not until later. I mean, but the way that a lot of people are doing it, the moment you're on a ventilator, you get deeply sedated until you get a tracheostomy and you're sent to an LTAC.
That's crazy.
So
That's crazy.
Things have to change. And I feel like until the public puts fire under our feet, we may not fully make the transition.
Well, I love what you're doing. I think this is wow, what a serendipitous find this morning to hear your story, your cause, what you're working on, and this is just so much common sense.
It really is. And yet, I think it makes me wonder, what else in my world or my life do I not question that's completely wrong?
Yeah.
Because that's what we're doing in the ICU. We go with what we know and don't ask what could be. But anytime anything's evolved in the world, but especially in medicine, is because someone asked why not, what if? And that was Polly Bailey back in the 90s.
Mm-hmm.
And yet she's been, I feel like, in large part ignored. Despite her work showing that it's possible to walk patients on ventilators.
I'll share a quick little analogy. Have you ever heard the cutting the end off the ham story?
No.
Okay. So there were 3 generations of women at Thanksgiving going to have a ham with their turkey. And they're in the kitchen, and grandma's there, mom's there, and the daughter. And the daughter's, early 20s, just getting her family started and stuff. And she looks over to mom because she was prepping the ham. She looked at her mom. She says, "Why do we cut the end off the ham?" And she says, "I don't know." So she looked over at grandma and said, "Well, mom, why do we cut the end off the ham?" And she said, "Oh, it's pretty simple. I had a 12-pound ham in a 10-pound pan, so I just cut the end off." So it'd been handed down for 2 generations without anybody asking, "Why are you cutting the end off the ham?" Okay. This is the same thing here. People aren't even paying attention. I mean, I'll say something that is so unpolitically correct at this point in time. This is as simple as 2 genders, 1, 2. Okay. It's that simple. Okay, guys. I mean, you can't chemically soak a person's body with chemicals that are going to make you numb and unconscious for lengths of time and not expect that there's not damage. You just can't.
And I think a lot of people don't even know that there's another way to do it.
Yeah.
So, this is never to demonize anyone.
Yeah.
Again, as someone that's worked in the field and also been the recipient of their care on both sides, I am just very sorry.
Fine. Yeah.
Okay, I'll come up. Okay. Can you go tell Dad?
Not a problem.
Oh, okay. Can you sit here for a second? The medical community is full of some of the best humans in the world.
Yeah.
And as I've been doing this podcast and people have been exposed to it, they are excited about it. They are hungry to save people, to prevent harm, to improve their outcomes. And so I just know that as everyone, especially the medical community, is aware of what could be and what's happening, it will change. So I don't think anyone's doing any of this maliciously.
No, I don't think so either. And I don't want anybody that's listening to think, I say this all the time, I am not anti-pharmacology, okay? Right. My existence is because I live today, the quality lifestyle I do, because there are good and fantastic drugs. But I just think that when people treat you because they don't know the outcome, the exact outcomes for you, that it's sort of, I don't know if it's reckless, but it's just, this is what we know how we do today, and there are better ways. And so I just think what you're doing is great. So,
thank you. Thanks for
I
spreading the
appreciate
word.
you coming on the show. Okay, so I know you got your family there, and we're authentic. We've had all kinds of crazy things show, and we never edit those out because we are real people. So quick last question for you. Now, I'm kind of a scientist. I'm a computer scientist. I spent my career in science and stuff, so computers. And so there's always an opposite to everything in the world, right? So, so we asked this thing about, in our modern Western world, we talk about a bucket list. And guess what? I have actually met the bucket list guy. He was on my show. Trav Bell, great guy. Anyway, everybody has these bucket lists of things they want to do before they, they leave this dispensation, okay? However, there's always an opposite, right? So there's a list of things that you don't want to do, okay? Now, that list is rhymes with bucket and starts with an F, but I'm not going to say that, okay? So what you've been very transparent today in helping us with some very serious subjects. So we always kind of like to end on a little lighthearted thing is here. What might be on your effort list that you're just not going to do? Now, I'll give you an example, okay? I will never go back and do a Sioux Dakota sweat lodge. Drumming, chanting, excessive heat, excessive humidity, not doing that again. Sardines, no, not going to do those anymore. So what might be on your list?
That's a great question.
And guess what? Next time somebody mentions bucket list, you're going to remember.
I mean, I feel like one of my biggest fears is harming patients. So I will never go to an ICU and just fit into their culture if it's against what I know is right for patients. And so I've actually had interviews in other ICUs, and then I say, I can change your outcomes. And they look at me like I'm crazy.
Yeah.
So I will never do that.
And anything just easy and simple? Not hugging a spider, not, going to skin fish or just, anything like that?
That's really hard. Because there are lots of things I would never do.
Right. Well, just name one. And you did, so.
I think I'm too fixated on that. And also my daughter's feeding tube beep in the background. Sorry if you can hear that.
Okay. All right. Well, listen, we'll let you get on to your family this morning. Thank you for coming on and sharing your story. And thank you for helping, I guess, wake up and alert our audience and educate them on this because it's a very important topic. So thanks
for helping me with it. Appreciate it.
Fantastic. Okay, folks, we're going to call that a wrap. Until next time, don't forget to stop by the show website, rexandrewshow.com, and you can get information about Kaylee and all the things that she's doing, and appreciate her time today. And so until next time, we just have the normal 3 things to say is be safe, but be bold and make it a great day.